Hello, ReproPsych, APRN Preceptees, and residents. We're here to talk briefly about risk discussions in the context of the perinatal period. Hello, my name is Sarah. I am a actively working midwife and Psych MP, currently working in a fully integrated reproductive psychiatry clinic at a FQHC just south of Boston. Our practice collaborates with OBGYN, substance use, and social services departments. This video is intended to be an educational video for our preceptees and residents and is not meant to replace a discussion with a medical provider for patients, and we have no financial disclosures. This is intended to be a brief concept overview and is accompanied by required reading material. Just see below in the comments. And should be intended to be started and finished prior to your residency or your clerkship. So please see the description below for your references and for review. We're going to go over risk discussions and what they look like in pregnancy and postpartum, as well as the structure we use here at DRP or the Division of Reproductive Psychiatry. You might hear me say DRP a lot. Then we're going to apply that structure to common cases. The example today we're using is SSRIs, which most folks find helpful. Please remember to write down your questions for your first week. So risk discussions are the classic tale of damned if you do and damned if you don't. So according to the American Medical Association's Code of Medical Ethics, informed consent requires patients to be informed of potential burdens, risks, expected benefits, and that's of all options of care. This includes the risk of foregoing treatment, and it's that final caveat that sometimes goes lacking in conversations around pregnancy. Research in reproductive psychiatry is heavily burdened by the lack of quality and quantity of information out there. In addition, often research talks about statistical significance, which does not always convey to clinical significance. This is why critical appraisal of research is so important. There are entire courses dedicated to teaching this topic. Unfortunately, APRNs do not get that same kind of research track in school as our MD counterparts. So this means that we have to hone this skill not only in school, but long after we graduate. If you are an individual that likes to open up a research article and read the abstract and the conclusion and nothing else, reproductive psychiatry is probably not for you. This is why this article is your first reading material. Your ability to be able to critically appraise research in reproductive psychiatry is going to be paramount if you choose to seek a career in women's behavioral health. So one example I like to use for explaining statistical significance does not always convey to valuable clinical or epidemiological findings is the elevated risk for postpartum hemorrhage requiring blood transfusion with SSRIs. Sounds scary, right? So Jackson et al. In 2024 reported on the doubling of the risk for postpartum hemorrhage requiring a blood transfusion, and in the presence of a benzodiazepine, this risk quadruples. So these are really scary things to hear, right? Double the risk, quadruple the risk. So we have to be careful about the language that we use with patients. I found that using absolute risk and the risks found in the general population to be really helpful when trying to give patients perspective of how much impact research findings actually have. So let's look at the baseline risk for postpartum hemorrhage that requires a blood transfusion. Per the International Journal of Obstetric Anesthesia, the absolute risk for postpartum hemorrhage requiring a blood transfusion is about 40 in 10,000 deliveries. This means that the absolute risk changes from 0.4% to 0.8% to 1.6%, making this event very rare, regardless if you're using an SSRI. So next important topic is the use of antidepressants in pregnancy. We see patients in our clinic from menarche to menopause, so you'll need to be familiar with the treatment of a wide range of conditions and ages. However, the vast majority of our patients will be in the perinatal period. So we want to start there. So this is your next two readings. These two journal articles do a great job of summarizing existing data, but even then, they're only a piece of what's out there. There is inherent difficulties for conducting epidemiological studies in the perinatal community. Due to this, an individual study is rarely definitive, and we need to look at information from multiple modalities to try to paint the most accurate picture we can for our patients. This is why it's important to realize that the medications that have been introduced to the market between 1980 and 2000, 91% have undetermined fetal effects, 3% have some known fetal risk, and only 6% of medications that have come out between 1980 and 2000 have actually no known fetal risk. And even then, very few medications on the market have specific indications for the use in pregnancy or specific information regarding the dosages in pregnancy. Further medications on the market that have declared information on risks to a developing fetus are based on toxicology and teratology studies of animals, and that may not be predictive of humans. So a lot of what we do in reproductive psychiatry is just basically read tons of research. Luckily, there is a new interest in the subspecialty, so new information is coming out all the time. However, that means constantly just trying to keep up to date so that we can convey the most up-to-date and evidence-based information for our patients. In DRP, we approach our risk discussions with birth parents in a structured way as to address the 5 domains that encompass the perinatal period. So we look at each of these contexts, but know that a full risk discussion requires you to talk to your patients about all these factors. So that means talking about congenital anomalies, impacts to the pregnancy itself, impacts to the fetus, its growth, its development immediately after delivery and during pregnancy, as well as lactation and a child's long-term neurodevelopment. So if all we do is talk about congenital anomalies, which I do find a lot of people do, then you're not having a full risk discussion. So for those without an OB background, it's important to understand that there are time-sensitive windows for different exposures. Most congenital anomalies occur within the first 8 weeks. Considering over 50% of pregnancies are unplanned, this is why discussions are so important to have prior to conception. The most important aspect to treatment is accurate dating. Is the estimated due date based off a sure last menstrual period? Is it based off an ultrasound? Is it an ultrasound that, when was it performed? Ultrasounds become progressively more inaccurate as you move forward in a pregnancy. So don't base big decisions off inaccurate data in pregnancies. For example, topiramate has produced abnormal pregnancy outcomes in experimental animals, showing an association between oral clefts with the use in pregnancy in some, but not all studies. So there's a potential risk that topiramate can convey a risk of cleft palate, but you see a patient at 24 weeks. At that point, the palate's already formed, and the weight that particular risk gave to that risk discussion, it no longer applies. So some medications can convey a risk to the actual pregnancy, and this can be through multiple pathways, but often is through placental perfusion. An example of this would be prescriptions of amphetamines after the 20 weeks gestation, being associated with hypertensive disorders in pregnancy, or the use of second-generation antipsychotics and elevated risk for gestational diabetes. But again, keep in mind that untreated illness in and of itself conveys a risk for additional obstetric complications, such as gestational diabetes, preeclampsia, and preterm labor. And each of these complications have multiple downstream effects. So the next modality is the risk to the developing fetus. So some medications and conditions can both have direct impacts on the baby. Untreated mental illness can convey a risk for infants being growth restricted or small for gestational age. In the context of SSRIs, often parents are concerned about what is now called postnatal adaptation syndrome, or PNAS, or what was once called neonatal neonatal absence syndrome, which is now called neonatal opioid withdrawal syndrome, or NOWS. So the next topic is lactation. Don't worry, we're going to go into all of that later on. That's a whole nother presentation. So next topic is lactation. Parents, if they choose to breastfeed, not all parents choose to breastfeed, and that is 100% okay. Typically, we are looking at relative infant doses of the medication that's being transferred into breast milk. So if that relative infant dose is less than 10%, we typically are pretty happy with that. That's not universal, though. I don't want you to see a relative infant dose of 8 and think everything is fine. We need to check each and every individual drug, and I'll show you how to do that. We have Hale's meds. Lac meds is another option. We pay for Hale's meds, and it's really great, so that's why we use that one. So one example of this is Lamictal is often used in pregnancy for mood stabilization, but also seizure prevention. Its relative infant doses range between 6.6% and 18.2%, but we still use it during postpartum with breastfeeding. The other thing to think about is that psychotropic medication can impact prolactin and by proxy milk production. So though a medication may be okay to use during breastfeeding for an infant, it can impact a birth parent struggling with production. So examples of this would be like Abilify, or to a lesser extent Wellbutrin. So last but by far not least is the long-term neurodevelopmental impact for children. This is typically a topic that has not a lot of information or research out there, but things are getting better, thank goodness. There's a lot of research coming out now that's very reassuring about the long-term neurodevelopmental impacts of a lot of medications. So let's put this all together. This is one of my old macros. When I start talking about risks, I typically start with what untreated depression and anxiety looks like. Little bit of the epidemiology, then we go over the impacts. These are the 5 domains I want you to talk to about in every conversation you have with the patient if they're pregnant or postpartum. these are what we're going to talk about. Or actually, if they're even considering conceiving, these are things that people should be aware of when you're talking about in the context of the perinatal period, or even reproductive age women. Again, remember, 50% of pregnancies are unplanned. So in regards to, we're going to talk about congenital anomalies, we're going to talk about pregnancy, we're going to talk about fetal development, we're going to talk about lactation, and then neurodevelopment. These are our 5 domains, right? Let's look at this case. So Jill is a 42-year-old gravid of 4, para 3, female at 8 weeks gestation with a past medical history of gestational diabetes in a prior pregnancy and a past psychiatric history of major depressive disorder with moderate anxious distress. She has been on Lexapro since her divorce 3 years ago and was later augmented due to sexual side effects. She presents today for consultation because she recently discovered she was pregnant last week and is scared her medications could hurt the baby. The father of the baby is not involved. She has a supportive sister nearby. She stopped therapy 3 years ago. Again, EPDS is 16 and GAD7 is 14. Mind you, she only found out she was pregnant last week. Keep in mind, these screeners are meant to be in the context of a 2-week period, right? So did that EPDS, it was 16 today. Was it 16 last week? Was she not feeling well before she found out she was pregnant? So she's on Lexapro 10 milligrams PO daily and 150 milligrams of Wellbutrin XL PO daily. And we remember she had started that for augmentation for sexual side effects. Is she having sex? Is the father of the baby that's no longer involved? Is he a picture? Is something where did she notice a vast improvement in her other symptoms when she started the Wellbutrin? So if the case is that she only started Wellbutrin for sexual side effects, less is more. We don't have a lot of research about individual medications' interactions with one another. A lot of the research we have is showing medication A has this risk, medication B has this risk. It doesn't show you the risk of medication A and B together, what that risk conveys. We just don't know. Polypharmacy is not our friend in pregnancy. So if she doesn't need the Wellbutrin, less is more. Get rid of the Wellbutrin. If she notices that her symptoms start to worsen or she doesn't feel as well, we could go up on the Lexapro. She's only on 10 of Lexapro. It's better to optimize a single agent versus having polypharmacy in pregnancy, because again, we just don't know how everything interacts with one another. So the other thing is, she's 8 weeks pregnant, right? Do we know she's really 8 weeks pregnant? I've had people come in, they think they're 8 weeks pregnant, and suddenly they come back to me and they're getting their anatomy survey because they're 20 weeks along and we had no idea. So don't make big decisions off unsure dating. Double check this dating. Is it a sure LNP? Is it off an ultrasound? When was that ultrasound performed? Is she already looped in with OBGYN? Has she had her intake yet? So we want to be in communication with her obstetric providers so that we can answer any questions and make sure they're not going to stop her medication, because that does still happen on occasion, not as often, which is wonderful, but it does still happen. So we like to make sure people aren't going to stop their medication. We don't want unstable people. So let's go into what our conversation is going to look like. Okay, so we're going to talk to her about the risks of her Lexapro. We're hoping that maybe she doesn't really need the Wellbutrin, right? Let's say it was just sexual side effects. It didn't really add anything more to her symptomatology or profile after it was added. We're getting rid of it. She's just going to be on Lexapro. So talking about SSRIs, this is my general macros for SSRIs. Now we have enough research where I look at each individual medication versus generalizations like this, but this is always nice to have too. So 2018, there was a huge meta-analysis of 29 cohort studies. It showed there is no identifiable association with SSRIs and congenital malformations among birth parents with psychiatric disorders. Regards to pregnancy, there is no difference in the prevalence of stillbirth, neonatal death, infant mortality. There's no association with preterm birth or low birth weight when controlled for maternal depression. We already talked about that risk for postpartum hemorrhage, the risk changing from 0.4% to 0.8 to 1.6%. This is a very, 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 very rare event. Mind you, even though we think something's clinically insignificant, it doesn't mean the patient does. So it really depends on, yes, we might think something's clinically insignificant. It doesn't mean we discard it. It doesn't mean we don't discuss it. It's something that we have to weigh that risk, and if that's a risk that the patient is willing to accept, because it's their body, it's their pregnancy, it's their choice. In regards to fetal development, research varies, but postnatal adaptation syndrome may occur in up to 30%. I can give you reassurance that more current literature is actually lovely and way more reassuring. It's way less than that. It exposes in late pregnancy, it can be manifest. These symptoms for infants can manifest as irritability, abnormal crying, tremor, lethargy, hypoactivity, decreased feeding, and tachypnea. Some of these symptoms are not uncommon in general for unaffected, unexposed infants. This is like 10% of unexposed infants will have these same symptoms. These are things that we want moms to, regardlessly if they're on a medication or not, to be watching for. So regardless of whatever you're on, every mother should be always monitoring their child for sedation, eating, weight gain, pees and poops, all the normal things. In most cases, the symptoms, if little ones do have it, it's mild, it lasts 3 to 4 days, snuggles fix the problem. Typically, at most, symptoms disappear altogether within 2 weeks with no treatment or minimal supportive care. There have been older research reports that talk about respiratory distress and persistent pulmonary hypertension of the newborn. However, this research that's showing this association is weak. And the absolute risk difference between the development of PPN, or persistent pulmonary hypertension of the newborn, after exposure to antidepressants in late pregnancy, it's like 1 in 3 in 1,000, as compared to 0.62 in 1,000. So you're talking about an increase of 0.62 as compared to infants in the general population. So again, we're talking about statistical significance and clinical significance. Is that our choice? No. It's the patients. We need to talk about these things because everybody Googles. So people are going to Google things and they're going to get scared and they're going to wonder why you didn't talk to them about it. So make sure these are in your conversations, and encourage your patients too. I learn so much from my patients. We have fantastic patients here. You will learn this. And we learn so much from them. And it's something that, again, we're looking at a moving target. I love hearing things from my patients, what they find. So be open to that and encourage them to reach out to you if they have any questions. In regards to lactation, all medications at some point, the vast majority, are secreted into breast milk. More data is available now for individual SSRIs. So we look at the individual now versus in general for SSRIs, though they are all fine in breastfeeding. It's just there's different caveats to them now. So Zoloft is like the gold standard. Least amount of the lowest relative infant dose of 0.4 to 2.2. There's also Lexapro, which is like 5.2 to 7.9. I use both of them all the time. Those are great. Prozac, I use that as well. I do notice a little bit more because the relative infant dose is higher, so 14.6. So I do notice that sometimes babies don't typically like Prozac as much. It also has a very long half-life. So that's the other thing to think about for Prozac. But again, these are just nuanced stuff. They're all fine. If in whatever medication keeps a birth parent stable, that's the one we want, regardless of it being Zoloft. I would never have a patient come in that was on even Paxil. Like, I don't use it. I don't particularly like Paxil. But if someone's been stable on Paxil for years, I would not take them off of that. I know there's a lot of controversy around Paxil. We will dive into that. That is a whole nother conversation. I'm just telling you, I would not take them off of it. I would leave them on the Paxil and we would talk about it because stability is paramount. And you can breastfeed with it. So the other thing is to think about is that we're going to talk about, remember we mentioned that sometimes medications can impact the development of, milk, having actual milk production. So keep that stuff in mind. SSRIs, that's not the case. You don't have to worry about that. So again, all moms were watching for feeding, poor weight gain, especially in younger, exclusively breastfed infants. And then also think about polypharmacy, right? When in combinations with other medications, we want to watch stuff. So in regards to child neural development, 2020, they had an awesome systematic review, 18 studies. It examined multiple aspects of neural development for long-term impacts of SSRIs for children. There was no difference in cognition, behavior, IQ, motor development, speech, language, scholastic outcomes. It found no consistent associations with antidepressant exposure after taking into account confounders. There was 11 studies that investigated psychiatric outcomes. After adjusting for confounders, perinatal depressant exposure was not associated with childhood psychiatric outcomes such as autism or ADHD. The ADHD, it's much more hereditary. I would be more amped to be concerned about an infant having ADHD later on down the line if they have a birth parent or a partner that have ADHD. It's much more hereditary versus it's not going to be coming from an SSRI. I think that was the confusion where in older studies are like, there's an increased risk for ADHD. I'm like, no, because the parent has ADHD. It's a hereditary component. So keep that in mind. So things to know. Care should be trimester specific and take into account the psychological, social, and physical impacts of pregnancy. If anything defines the biopsychosocial model, it is the perinatal period. Treat symptoms, not numbers. So you'll notice that on screeners, even PHQ-9, EPDS, GAD-7, at the very bottom of the page, it talks about the patient. It says, what do you rate the severity? So you might see an EPDS that says 8, but then they rate the severity as very severe. So yes, it's only an 8, but it's really severe for them. So you got to explore that. Okay, it could be something more. The other thing is to treat to remission. We are exposing a parent to risk by starting them on a medication. I know people don't like to hear it, but it's fact. Walking out of the house conveys risk. So how can taking a medication in pregnancy not convey risk? We have to it's one of those kind of standard things. So if we're going to expose a birth parent to risk, we have to make it worth it. Because if we expose them to the risk of the medication and we don't take care of the risk of the untreated depression and anxiety, the only thing we're doing is elevating their risk. So you want to treat to remission. Okay. The other thing is to make sure that you have a close relationship with the OB and the behavioral health providers. I am so spoiled here. I literally am housed on the OBGYN floor, so I can walk out my door and knock on the door of an OBGYN or a midwife and be like, hey guys, I just wanted to talk to you about this patient. It's amazing. As I said, you're going to love it here. But not everyone has those kinds of experiences. So when you leave here and you're going elsewhere, make sure that you talk to your patient about having that open dialogue with their OBGYN provider if you do continue in women's behavioral health. The other thing is don't make big decisions in isolation. Okay, don't be afraid to ask for help. Things are changing so fast in this subspecialty. We all have to communicate and we all have to talk to make sure that we're staying up to date on things. Be open to new information. Be open to new information coming from your patients. As I said, I adore our patients. They have so much knowledge and they find so many things and bring things back to me, and I love that. So resources. Left side, patients. Right side, you. So for patients, all the good things. For you, I want you to focus on the perinatal mental health certification from PSI is fantastic. Don't worry about that now. That's after you graduate. Same thing for the National Curriculum in Reproductive Psychiatry. It's fantastic, but after you graduate. The MGH Center for Women's Mental Health, that you can do now. Same thing for the Psychiatric Academy. If you have time, focus on your school. I totally get that. The other one is ReproTox is what we use here for looking up information for patients, specifically for each medication. We use Hales Meds, though LacMeds is great too. For substance use disorders, Great Center is amazing, and they're at BMC, so I'm obviously partial. There's also Marseille of North America, which is really great, has tons of resources. So these are my go-tos. The other one is MCPAP for Moms, which you guys will know is at UMass. Lots of references, okay? If you have any questions, don't be afraid to reach out. I'm super excited to have you in clinic, okay? You have a great day. We'll see you soon.